Welcome to the Oral Surgery Fight Club podcast. This is a collection of mock cases in the field of oral and maxillofacial surgery in a question and answer format conducted on Zoom. Enjoy.
Okay. I'm going to share my desktop. I'm going to minimize out of that. Okay. So this is part of section 2, trauma, implants, reconstruction, dental alveolar. They probably go along with one another. Again, there's 48 minutes to get through these 4 cases. I don't know whether they specifically allot 12 minutes to each section. They probably try to keep it timely, but different topics may blend into one another. So let's go ahead. 908. Examiner, examinee, you guys ready?
Mm-hmm.
All righty then. Thanks.
Okay, Colin. So, can I go? Start. Okay. 14-year-old male presents to your clinic with associated pain in the left mandible. Says that he had a lesion resected months ago. Can't really remember the name of it. And then lately, he's noticed some increased swelling of his anterior mandible. What do you want to?
So first, I want to get a detailed past medical history for the patient, medications, allergies.
Okay. Next slide. So, patient has a history of hypertension, hyperlipidemia, CAD. He's on lisinopril, atorvastatin, and 81 milligram of aspirin. Allergic to penicillin. You dug into his medical history a little bit because you have access to the chart of the hospital that he was treated at. And sounds like he had an ameloblastoma resected 6 months ago. He otherwise has had no other surgeries. He smokes a pack a day, drinks alcohol every day. He has no illicit drug use. Excuse me.
All right. So patient's in my chair at this point.
Yeah. Mm-hmm.
Okay. So I want to start with a physical exam. So extraoral exam, looking for asymmetries, any fistulas, any sign of infection, and then I'll palpate the neck for any lymph nodes. Check his facial nerve, see if he has any defect from the previous resection, and his cranial nerve 5 as well, see if he has any paresthesias. Then I'll go intraorally. I'll check for soft tissue defects, see if the plate is kind of dehisced intraorally, what the quality of the soft tissue looks like, any swellings again, things like that.
Okay, so he's got no intraoral or extraoral fistulas. His cranial nerves are all intact. You look inside of his mouth, and you don't see any plate exposure, but he's particularly tender, kind of in that anterior mandibular area. You notice some swelling within the vestibule, and then you also kind of palpate like a drop-off defect, and you can kind of feel the plate underneath on the left side of the jaw. So you take a panel. Next slide. And Patel shows this. Tell me what you see.
So obviously this is a Panorex status post resection of a lesion of the left mandibular body. There's significant moth-eaten radiolucency of the anterior mandible and loosening of the hardware. You can see floating screws both in the proximal and distal segments. There's obviously that tooth number 32 with an infective lesion. So for this, I would be concerned for recurrence versus possibly a de novo squamous cell. So first thing I'd like to do is get some more imaging, get a CT scan.
And then what, sorry, I don't have any CT slices, but anyway, you say you get the CT scan, it kind of confirms everything that you see. There's no like lymph adenopathy really. So you're not really concerned about getting a PET scan or anything like that. And like I said, the last time it was resected was ameloblastoma. And so based on kind of like what you're seeing, what is your treatment plan? How would you go about this?
Well, for this patient, I think I would recommend an incisional biopsy before proceeding any further. So I would do that in the clinic.
Okay. Patient is scared. How would you do it in your clinic?
I would do IV sedation.
Okay. Is there anything you're concerned about regarding his medical history and IV sedation?
So if I remember correctly, at CAD, hyperlipidemia, hypertension. So yeah, I'll get a complete set of vitals, see how well controlled this hypertension is. With the CAD, I would ask about his exercise tolerance, try to get a feeling for his metabolic equivalence, and I'll start there.
Okay. Would you be concerned about, would you get any labs beforehand? What would you be concerned about? It says, Doc, I've been drinking for 40 years.
Yeah. So I guess we could get a liver panel and a coags.
Cool. Yeah, so liver panel, coags, labs, everything kind of turns back normal. You do your biopsy. It's recurrent amylo. What's your treatment plan?
Okay. So for recurrent amyloblastoma, I'm gonna have to plan for another resection. It looks like that lesion is going to be kind of all the way to the angle of the contralateral mandible with I'm planning a 1 to 1.5 centimeter margin. So in preoperative planning, I'm going to get a new CT scan for VSP to do a custom reconstruction plate. I'm also going to be planning a fibula free flat reconstruction for him. So preoperatively, I'll need a CTA of the lower extremity to confirm 3-vessel runoff. I will need obviously just lab CVC BMP typing cross. I think that's
describe your surgical approach.
So for this patient, I think initially before opening for fibula, so it can be a 2-team approach. I don't personally harvest my own fibulas, but I would, regardless, I would have them start making an incision in the neck, kind of an apron incision in this case, through skin, subcutaneous tissue, through platysma, and then a subplatysmal flap to the investing fascia, dissect until I reach the inferior border of the mandible, and then expose from angle to angle, basically. During the dissection, you got to be careful to not or to preserve the vascular pedicles for anastomosis. So you try to, if you have to sacrifice a vessel, do it as proximal as you can.
Okay, next slide. Sorry, I'm running out of time.
Okay.
Okay, he tells his buddy at the Amyloblastoma Anonymous monthly meetings that you're the best in town, and he comes sees you too. So you take a panel and you see this. So what do you think caused this?
Well, this does not look like a custom reconstruction bar, so I think most likely it was over contouring or back bending during the contouring of the bar that weakened it in that area.
Okay. Let's pretend this defect measures 5 centimeters wide. How would you reconstruct this? What are your options?
So it all depends on how the intraoral soft tissue looks. As long as I have good intraoral soft tissue for this defect, I would probably do an allogenic graft with BMP.
Okay. Any other options?
Yeah, I mean, you could do an anterior hip. If it's 5 centimeters, that's probably the limit of an anterior hip, how much bone you can get. Obviously, you could do a posterior hip.
Okay.
Or
Patient,
then there's vascularized grafts.
Patient doesn't want to use, another human's bone in himself, so he wants to go for the autogenous graft. So which type of iliac crest would you use?
I would do an anterior iliac crest. Yeah.
Okay. Describe your procedure for that.
So an anterior iliac crest graft, patient's prepped with a bump under the hip. The ASIS and iliac tubercle are marked out. An incision is 2 centimeters lateral to the crest, starting a centimeter posterior to the superior spine and ending 1 centimeter before the tubercle. It's through skin, subcutaneous tissue, scarpus fascia, down to periosteum. I do a medially approached anterior hip graft, so I would reflect the iliacus medially. And in this case, I would take a block as well as corticocancellous graft from the medial aspect, undermining the crest.
Okay. Your patient comes back with burning of the thigh after your harvest of the hip. What's going on?
I'd be concerned for myalgia paresthetica, which is damage to the lateral femoral cutaneous nerve.
Okay. And then patient comes back with drainage from the extraoral site. What are you concerned about?
From the neck, you're saying?
Mm-hmm.
Okay. So either over contouring of the reconstruction plate that's kind of eroding through, or an infection from the graft that's kind of tracking extraorally.
Are we time or no? Sorry, I didn't see it. Right.
I think we have 2 minutes, maybe.
2 minutes? Okay.
Yeah.
All right. Okay. I was like, wait.
Oh, great.
Okay, great. So
yeah, we still have time.
Hey, so, okay.
Colin, what does this look like? Sorry, keep going.
No. Okay. You get to the OR late. Oh, sorry. Your patient comes back and you see this. What's going on here?
So you have dehiscence of the plate through the soft tissue.
Okay. Okay, cool. So then you know, at this point, then you decide to do a free fibula flap. Like, would you keep, you decide to take this out, do a free fibula flap because the defect's like too large. Would you keep the skin paddle in your free flap?
Yes, I definitely would.
Benefits of keeping it. Okay. What are the benefits of keeping it? If there's like no true soft tissue defect. Sorry, like to kind of skip around a little bit. This is actually my question for the last one, but anyway.
So if you don't actually need soft tissue for it, it still helps in monitoring the flap. You can kind of do pinprick tests and check for kind of capillary refill.
Okay, and then now your free fibula patient, like they come back like 1 week post-op, they're complaining of a cold, swollen leg. What do you think is going on?
I'd be concerned with compartment syndrome of the leg.
Okay, and if it is compartment syndrome, what do you look for?
So I would check DP and PP, dorsalis pedis and postiotibial pulses, see if I have palpable pulses in the leg. And if I have no pulses, I think a fasciotomy is indicated for this, or reopening the original incision. Whichever.
Okay, you get to the OR late, and now you have to amputate the patient's leg. So now the patient goes to the nursing home, and then they call you and tell you, like, they show you this photo, and I think you like, what do you see here? What do you do for this?
So for this, the patient's gonna have to go back to the OR. We're gonna have to take out this plate and try to get this soft tissue to heal somehow.
Okay, that's all I had. Sorry. I bounce around a bit because like I think that's what they're gonna do on boards, is just kind of bounce around some cases and just ask random questions. So I just kind of wanted to do that on purpose a little bit. But anyway, this is what I assume.
You're completely right. In a topic like this, I think the examiners can skip around and ask you a whole bunch of different things, even if it's not the same patient. Like obviously it isn't the same patient going the whole way through, but sorry, you can review the case.
Yeah, they did that at the Nashville one too, but yeah, you did awesome, Colin. Like, you got everything right, so I don't think you missed anything that I asked. It was really good.
Well, thanks, it's good.
Yeah, you got all the, like, you know, the procedures. You know, you did everything in terms of like the recurrent one. You got the incisional biopsy first, and then you got good margins because it was recurrent amylo, so you want to go even a little bit more. You got the custom plate. You went with the fibula right away instead of trying to do something else, you know. And then on the other one, you tried the hip first, you know. I just basically wanted you to like talk about the different methods of reconstruction, and just kind of hit those key points. And then you went through a lot of the complications really well, like the plate fracture, which is from overbending, and then the plate exposure, the issues with the AICBG, like the myalgia paresthetica, all that stuff. So, and then like the only thing I think when I was alluding to with extraoral, like is a like intraoral, extraoral fistula, basically. But I don't know if I did a good job like asking that question. So I think it was kind of, but yeah. Anyway, great job. Really, really good.
Yeah, I thought it was a good case and well presented, well answered. They can skip around. Just know your reconstructive algorithm, whatever you're comfortable with. You don't have to know how to harvest a fibula. I don't think.
No, I don't think you do. At least that's what Press said at the Nashville course.
Yeah, whatever you would do, just know how to do it. Make sure you can spit it off like an op report.
Hey yo. I gotta sharpen my swords for the oral boards. I learned them from Patel and he's the Lord. And I'm his protege, you know I'm gonna slay all these motherfucking questions today. Cause I got the sound bites, they're gonna make these old men go ooh ah like some afternoon delight. Yo, I got these questions in my sight and I got the answers. Yo, my answers is so ill, they give you canker sores.
Thanks for tuning in to Oral Surgery Fight Club. For uncut episodes and sound bites, go to osfightclub.com.